Hi,
Hi.
everyone. Sorry, Duncan. Um, I'm Ellie Flickos and I am room captain for room 3. We are ever so sorry, my pump just alarmed. Uh, we are very excited for this talk by Duncan Stang on the importance of foot screening and risk stratification leading to a treatment or management where appropriate. This is a really important issue for diabetics, so it's really great to have Duncan to speak to us about it. Before we start, just a few housekeeping rules. Please do set your name as per the instructions in the email you were sent. Um, your video and audio won't appear as this is a webinar, but it will appear in the chat, and that's for security, but also to allow others to see a bit about you and to encourage the family feeling we get at the in-person conference. I'm sure I don't have to remind you, but all comments must be respectful. Bad or offensive language will not be tolerated, and our tech support will kick you out if that happens. Please do use the chat and or the question and answer function to make comments and ask questions throughout the webinar. I will collate the questions and ask them to Duncan at the end of his presentation. I'd also like to take the opportunity to thank our sponsors and encourage you all to visit their virtual booths at the breakout sessions. So without further ado, I would like to introduce Duncan Stang for this webinar. Thank you very much, Duncan.
Well, thank you, Ellie, and thank you to Type 1 UK Today for inviting me to give this talk. At present, I am Diabetes Foot Coordinator for Scotland, but just to let you know, I've been a podiatrist for over 40 years now, and my current role is a non-clinical role. I retired from my hospital clinic 2 years ago. But I now have the role as Diabetes Foot Coordinator for Scotland. But as I say, I've worked in diabetes care for just over 30 years now, and I have dealt with all aspects of diabetes foot care. But today, I'm really going to talk to you about screening and risk stratification and what all that means for you as a person with diabetes. So, we all know that diabetes is a lifelong condition. But consultations with doctors, podiatrists, and other healthcare professionals only make up a minute percentage of the time that you live with your diabetes. Now, these consultations are essentially to inform you and advise you on how best to self-manage your condition. We have to remember that diabetes is essentially a self-managing condition. And I feel this is especially important when it comes to your feet. So when we're talking about diabetes foot screening, I generally look upon this as the cornerstone of any good diabetes foot care service. Screening is like the foundation to build any good diabetes service on. And this should be carried out annually and will only take a couple of minutes when it is carried out properly. So why should you, as a person with diabetes, have an annual diabetes foot screening? It informs you of your risk of developing a diabetic foot ulcer that could lead to life-changing complications. And it informs you of who you should see and what service you should receive according to your risk to prevent or treat any problems going forward. So what does having a diabetic foot screening involve? The person, when they carry out the foot screening, the first thing that they will do is they will visually look at your feet. So the person carrying out your foot screening will check for what we call structural deformities or abnormalities that could lead you to having foot problems. Now you'll see the image on the left-hand side here. That's an overlying second toe, and that is very liable to get pressure from the top of footwear, and that could rub that toe create a break in the skin which could lead to an ulcer. And the image on the right hand side, you'll see how this patient has a hallux valgus, or what we call a bunion. And yet again, that could lead to an area of pressure which could cause a break in the skin, which could cause you a problem. The person checking your feet will also check for any areas of callus or hard skin. I don't, when I mean callus or hard skin, I don't mean a bit of just a small amount of dry skin around your heel or something. I mean actual areas of hard skin like you can see here. Now, the reason that that is a problem is hard skin can cause pressure on the underlying tissues, which could result in a breakdown of those tissues. And usually areas of hard skin are associated with areas of high pressure. And that is a warning sign for anybody who is, for you as a person with diabetes, but as for the person who is carrying out your foot screening. So we also check for any areas of broken skin, and that's something that you'll also be doing, and I'll come on to that later. But during the screening process, the person carrying out the screening will check for any areas of broken skin, because that is very important, because any area of skin that is broken is a portal for infection, and that could lead to further problems. So the person will also be assessing if you can self-care. I.e., what I mean by that, can you get down to reach your feet so that you can check them? And can you see your feet so that you can visually inspect them to see if there are any problems? Your circulation will also be checked during the foot screening process, and they generally check 2 pulses on each foot. The first pulse that they will check is what they call the dorsalis pedis pulse, and that's on the top of your foot. And you'll see in the right hand image here, there are 3 small white dots. Now that is roughly where that pulse is located on your foot. Not everybody's pulses are palpable by the person carrying out foot screening, and that could be for various reasons. That could be because the blood vessel runs quite deeply, or there's maybe some swelling in the feet, or whatever. So if somebody can't feel the pulse in your foot, they may send you for a further assessment of that, but it doesn't mean to say that there's major alarm bells ringing. The other pulse that we check on your foot is just behind the ankle bone, and you'll see in the right hand image here the 3 small white dots there, and that shows you roughly where that pulse is, and the person carrying out the foot screening will know where to locate that pulse. And we say if the person carrying out the foot screening can locate either of these pulses with the use of these 2 fingers, then the perfusion, the circulation to your foot is assessed as being absolutely okay. So the next thing that the person will check, or you will have checked during your screening process, is that you have feeling in your feet. This will be done with what we call a 10-gram monofilament, and that is essentially a small piece of nylon that will be tested against each of these spots in your foot. And this is not painful, obviously, and it will just be enough pressure so that that piece of nylon can bend. And this will be done probably with your eyes shut. The clinician will touch it probably on your arm beforehand so that you know roughly what that should feel like. And the importance of this is that some people with diabetes sometimes lose a bit of feeling in their feet, and that is called neuropathy. And the problem with that is if somebody has lost some feeling in their feet and lost the perception of pain, then they might not be aware when they are developing a problem with their feet, and that can prove very problematic. So this simple test, which will be done with your eyes shut, and you'll have previously felt it on your forearm so that you know what to feel for, and the clinician will ask you each time that they touch your foot if you can feel any, if you can feel that on your feet. And if you can feel that on 8 or more of these out of 10 sites, then you'll perceive to not have any deficit in your perception of pain, which is good. But if you can't feel if you feel less than 8 of these, then there may well be a slight lack of feeling, and you will need to be advised on how to manage that going forward. So diabetic foot risk stratification and triage. This is what basically the clinician will refer to during your screening program, and it should let you know what it means for you as a person with diabetes. There is no point in going for a foot screening and leaving with no knowledge of what your risk is, what that risk means, or whatever, and somebody has just filled in a form. You really need to know what your risk is and what that means for you as a person with diabetes. So let me take you through this risk stratification. I'll just have a small drink of water if you don't mind. Down the left-hand side here, it is split into different sections: low risk, moderate risk, high risk, in remission, which I will explain a bit later on, and active, which is active foot disease. And during the screening process, depending on what the clinician finds, you will be assigned one of these risk levels. So let me just slowly take you through this to let you see what's involved in this process. So somebody who is low risk, they have no risk factors, i.e., or e.g., you have no loss of sensation, no signs of peripheral arterial disease, that means your circulation is fine, and there's no other risk factors. So that means your screening has been absolutely perfect and there are no problems. So what does this mean for the person who has had their screening carried out and they are assigned low risk? That person should receive an annual screening by a trained healthcare worker. This doesn't necessarily need to be a doctor, a nurse, or podiatrist, just anybody who has the competence and capability to carry out this simple task of foot screening. And following that, you will agree a personal foot care and self-care management plan. Now, why is this a self-care management plan? Because anyone who is low risk has no greater chance of developing a foot ulcer than somebody without diabetes. You're essentially, you have a 99.6% chance of being ulcer-free for the next 2 years. But you should probably still you will be given some footwear advice if that is required, and you'll probably be given written and verbal education, including information on how to access podiatry if you needed to. You'll probably be provided with cardiovascular risk reduction information, because that is very important to all people of all risk with diabetes. And if you are a smoker, you will be encouraged and signposted to a smoking cessation program. So if you are moderate risk, that means you have been detected as having one risk factor present, i.e., you've got a bit of loss of sensation, or you've signs of peripheral arterial disease, or you're unable to, or you do not have any help to self-care. And the other risk factor in there is something that you may or may not know of, and it's an EGFR, and that is signaling end-stage kidney disease when it's of a level of less than or equal to 15. That is not a test that will be carried out during your screening program. That information will be pulled from elsewhere, and that measurement is usually taken if you've given any bloods or whatever previously. So what does moderate risk mean for you if that is the risk that you've been assigned? Everything that happens in low risk should still probably happen, but you should probably be getting an additional assessment and an agreed treatment and management plan by a podiatrist. So now that you have a risk factor, it's now maybe not just the healthcare worker that you should be seeing who is qualified to carry out foot screening, but you should probably be seeing a podiatrist for possibly just a one-off assessment to make sure that that risk factor is hopefully not going to tip you over into developing a foot ulcer, and having a treatment and management plan put in place, agreed with yourself to try and prevent that happening. There will be a review of footwear, and in the case of people who have got feet who don't easily fit into short-bought shoes, there may well be the provision of specialist footwear and insoles measured and fitted by a trained healthcare professional or an orthotist. So that is moderate risk. So high risk, that means you have more than one risk factor. So you have two or more risk factors. And that could be a combination of loss of sensation, signs of peripheral arterial disease, callus or deformity, unable to or no help to self-care, and an EGFR of less than or equal to 15. A combination of all these problems will put you in the high risk category. And the in remission category, well, the high risk category means that you're at high risk of developing a foot ulcer, but you have not developed a foot ulcer up to this stage. But if you're in remission, that means you've had a previous ulceration, which has healed over, but we never talk about an ulcer being completely healed. We talk about it being in remission, because there is a chance it could come back unless you follow certain guidelines. So the person who's in remission has had a previous ulcer, a previous amputation, or has had something called a Charcot foot, but that has settled down. So what should happen for the people that fall into the in remission or the high risk category? There should be an assessment by a podiatrist experienced in the diabetic foot. Now, that is somebody who has got a lot more knowledge regarding the diabetic foot. So if you see from low risk, it is a healthcare worker just trained in screening, but the person dealing with the high risk or in remission category is a person, a podiatrist experienced in the diabetic foot. And there should be referral to other relevant specialists as required, and that could be, you might need to have your circulation dealt with, it might need various other aspects of care might need to be dealt with, and the podiatrist experienced in the diabetic foot will know who to refer you on to. And there will be a further review of footwear and insoles, and especially for those people who are in remission, to try and prevent them from re-ulcerating. So if you're unfortunate to fall into the active foot disease category, that means you have an active ulceration, you have an active infection with or without poor circulation, or you have gangrene or an unexplained hot, red, swollen foot with or without the presence of pain. Now, what needs to happen in that circumstance? In that circumstance, you need to be referred to and managed by a member of the multidisciplinary foot care team, which are, I know in Scotland that they're mostly based in the hospital setting. It depends what your health board adheres to, but some will be in hospital settings and some might be in community settings. But in some cases, you might not be sent to that multidisciplinary team if it is very obvious by the person that has assessed you that it is purely to do with a poor circulation problem. And in that case, you may be referred directly to vascular, which will obviously be in a hospital. So that is the traffic light triage system, and that is it all pulled together and all joined together. So once you've had your screening, you should know whether you're low, moderate, high, or whether you're in remission, or whether you have active foot disease. You should know what that means for you as a person with diabetes, and you should know what treatment that you should be receiving according to your risk. Because as you can see, there's a very different requirements for somebody who is low risk as for somebody who has an active foot problem. So it's a simple and it's a visual system. I like visual systems because you can visualize that, and it isn't a traffic light sort of system, so it's easy to follow. This has been part of, I developed this system and it's become part of the guidelines in Scotland, which are the SIGN guidelines. It has been adopted down in England by the NICE guidelines, and it has been recognised and endorsed by Diabetes UK in their Putting Feet First campaign, the College of Podiatry, the Primary Care Diabetes Society, and the British Association of Prosthetics and or orthotists. And it has been adopted throughout the rest of the UK, and there are many European countries, and I think Canada has also adopted this system. So it is widely recognised because it is simple to follow, and it is what we should be following as clinicians, and you as patients should be recognising and knowing what is happening for you. So what do you do as a person with diabetes? What do you have to do? First of all, you should be attending your annual foot screening appointment. And if you have not had a foot screening carried out in the last 12 months, inform whichever healthcare professional that you are seeing that you are due a foot screening. Take control of that, and don't be afraid to say to any healthcare professional that you see, well, this has been over a year since I've had my foot screening. Can you carry it out, or can you refer me to somebody who will carry that out for me? And remember what I said earlier, diabetes is a self-managing condition. So what can you do to prevent foot problems? The most basic and important thing that you can do is to check your feet daily. And what I always said to my patients was, when you brush your teeth, check your feet. So most people brush their teeth twice a day, in the morning and the evening. So by association, when you're carrying out that task, you should just spend a few seconds and check your feet. And if you find it difficult to see the sole of your foot, then the use of a mirror can be very helpful as well. So a quick visual check between the toes, round the heels and the sole of the foot, just to check for various things that we can discuss. So what should you be looking out for? Any break in the skin, as we discussed earlier, any areas of heat, redness, inflammation, blisters, anything like that, and check between your toes and the soles of your feet. And as I said, use a mirror if you need to. Sometimes some people need to have their partner or carer doing this for them, as they can't physically get down to do this, or they have a problem with their sight, or a problem with mobility or something. And if that is the case, then it's just a simple check by carer or partner. I would also advise applying a moisturizer cream. I would apply it daily, but don't apply it between the toes. If you apply it between the toes, it will sit in there and cause that area to become macerated, or mushy is the other word that we can use for that. And that's not good, because that can reduce the integrity of the skin. It can easily be applied while you're checking your feet, or while your partner or carer is checking your feet. And if you find that your skin is very dry, you can use a urea-based cream, which is very good for very dry skin, and that will also be available on prescription. Most people with diabetes can deal with their own toenails, although a lot of people are very nervous about doing this. But this is very dependent on risk. But your partner or carer can maybe be of help if you find that you can't do that. What I would advise is that you do not cut your nails too short. Don't cut them down the side. And some people would say, oh, you cut them straight across. I don't think that is necessarily completely true. I would say you would follow the curvature of the end of your toe and use the nail file to ensure that there is no rough edges, and use a nail file on a regular basis if you're unsure about cutting your toenails. If you think that that is maybe putting you at risk of cutting your skin, or you're just not happy about that, then the other alternative is to use a nail file on a regular basis. If you are advised by your podiatrist not to cut your own toenails, then obviously you wouldn't do that, because your podiatrist will have advised you on the fact that they think you're at risk of carrying out that task, and you're at risk, if you cause a break in the skin, of that causing you a problem. But as I say, most people, especially the low and maybe the moderate risk patients, cutting your own toenails is absolutely fine. But if you are advised not to do it, obviously you wouldn't. So footwear. When we talk about footwear, I would always say get your feet measured and don't fall into the trap of buying shoes in a bigger size, because if you buy shoes in a bigger size, it means that your foot may, what we call piston, and it could move back and forward within the shoe, and that can cause you problems with rubbing or stubbing of your toes. So I would always say get your feet measured and get the right size for yourself. Lacing shoes are best because they hold your foot in a good position and stop your foot sliding about within the shoe. And when buying shoes, I would say break them in by wearing them around the house. And what do I mean by breaking them in? I would say maybe wear them around the house for half an hour or an hour, and then take them off and check your feet. And you're checking again for any areas of redness, any areas that you think a shoe's rubbing or having any problems. And the reason I say doing that in the house is if there is a problem with that footwear, which remember, you might not, if you've got lack of feeling in your feet, you might not be able to feel the shoe rubbing. And that is why you've got to check your feet for any signs that they might be rubbing. And if you've only worn them around the house, then you can take them back to the shop. But if you feel that they're okay, then use them for short distances outside. I would say short distances to begin with. I wouldn't go on a 5-mile hike in a brand new pair of shoes. I would use them for short distances and checking your feet. And if you require prescription footwear or insoles, you can be advised by that by your podiatrist. And I wouldn't be so worried about that these days. The prescription footwear that is available are a lot better looking than they used to be, and they might just have a bit of extra depth or a bit of extra width if that is what your foot requires to keep it safe. I would also say always check footwear before putting it on. Now, what are you checking for? You're checking that nothing has fallen into your shoe that is going to cause you a problem. And yet again, that is very important for people who have lost some feeling in their feet, because if something has fallen into your shoe and you put your shoe on and go for a walk and you can't feel that it's causing you a problem, then that is a problem for you. But just to quickly put your hand inside to check for any foreign objects will only take a matter of seconds, and it can be very, very crucial to do that. And also detect for any rough or worn areas inside the shoe that could cause some rubbing on any area of your skin, which could cause a break in the skin. So it's just these simple things that we need to do. I would also say that walking barefoot is not advised. Walking barefoot, it can be dangerous, basically, because you can stand in any sharp objects, and you may well stub the toe, especially if you get up during the night and it's in the dark. You can stub the toe at the end of the bed or whatever. So I would advise against walking barefoot, especially if you have lack of feeling in your feet. And that applies for being on holiday as well. Sometimes being on holiday can be a very challenging time. And if you're somewhere where they're in a warm climate, around a swimming pool, you might find the tiles can get very warm. If you're on a beach, the sand can get hot. And especially if you've got lack of feeling in your feet, that can cause you a problem, because I've had many patients come into my clinic who have burnt the soles of their feet and at the time of didn't realize. Also, wearing of flip-flops, if you're not used to wearing those, because of the way the strap quite often goes between the big toe and the one next to it, that can cause rubbing and cause problems. So be careful, and especially careful when you're on holiday, because that can be a challenging time. There are risk-targeted advice leaflets, and these are available from the College of Podiatry. Now, this web address below, don't think that you have to quickly write that down at the moment. That will be shared on the chat site at the moment, so that you'll be able to look at that. You'll be able to look these up, and there are very, very good nationally agreed risk-targeted advice leaflets, depending on your risk, and ones that cover footwear and holiday advice and different aspects of care. So they are very worthwhile. So what should you do if you notice a problem? I would say don't delay. Contact your podiatrist, practice nurse, or doctor. Most diabetic foot problems are treatable, but receiving the most appropriate treatment quickly is absolutely paramount. Don't think, oh, it'll go away and it doesn't matter and this, that, and t'other. If you notice a problem, seek treatment, because the quicker you seek that treatment, the better chance the clinician that you will be seeing has of dealing with that problem. And no clinician will ever say to you, oh, you didn't need to come and see me about that, you're overreacting. And they would much rather that you appeared early and got assessed, and anything that was a problem got dealt with quickly. So, in summary, do attend your annual foot screening. Make sure that after your foot screening, you know what your risk is and understand what that risk means for you. Know what to do and who to contact if you have a problem. Now, if you don't know at the moment who you should be contacting, I would find out who that is now and have that number handy. Now, whether that's for the nurse in your GP practice, whether that's your GP, whether that's your podiatrist, and especially during these times of COVID and the current pandemic that we're in, the health service is open for business, and the podiatrist will want to see you if you have a problem, and they will fast track you to the most appropriate treatment. So do not, especially at the moment, think that, oh, well, I'll just look after this myself. I would make sure that you know who to contact and have that number handy, because you never know when you might need it. And the quicker you act, the better. So, and I'll come back to the most important thing that you can do is to check your feet daily. And remember what I said earlier? When you brush your teeth, check your feet. It's a very simple association, and that could pay you great dividends moving forward. Thank you very much for listening. I hope that was helpful, and I will now be directed any questions that you may wish to ask me. Thank you very much.
Thank you very much, Duncan. That was really, really great. I think that that was really helpful. I've been diabetic for 18 years. I've been having my feet checked for several, and I'd never heard of the traffic light system, so that was really informational. Thanks. I have got some questions for you. So from Lynn, what age does this screening start at?
I'm pretty sure the screening process is now, I think it is 18. It's either 16 or 18. I don't think, I would say that certainly nobody needs to get their feet screened under the age of 16. That's not to say that the person with diabetes shouldn't be checking their own feet, but I don't think you need to go for a structured screening under the age of 16.
Great, thank you very much. Hope that answers your question, Lynn. I then asked, is this the same in England and Wales? But you answered that question within the presentation, so thank you. Lynn also asked, what's EGFR? Is that to do with the kidneys?
Yes, it is. The EGFR, the number that I mentioned there was less than or equal to 15, and that is severe kidney problems. So yes, it is to do with the kidneys, and especially end-stage renal disease, which can impact greatly if you have diabetes, and it can impact greatly on your feet and really reduce any healing powers. So somebody with diabetes and end-stage renal disease has to be especially careful, and it is a major risk factor to somebody developing a foot ulcer, and also a major risk factor in somebody not being able to achieve proper healing if they have a foot ulcer.
Okay, thank you very much.
Thank you for asking these questions, Lynn.
Peter says, having had type 1 since 1956, goodness me, Peter, well done.
Well
Uh,
managed.
well managed. I'm delighted to still be in the low risk category.
Yep.
However, should I receive any help from a podiatrist as I age, or will that only occur when a problem occurs?
I would say if you're low risk, as I said in the presentation, you have no greater risk of developing a foot ulcer than somebody without diabetes. You've obviously managed your condition extremely well, as you're still in the low risk category. But I will also say there are many people who do manage their condition extremely well, and they are just unlucky that they do develop problems. And it is not a reflection on their care, because some people manage their condition exceptionally well and they get away without having any changes to their feet. But if you're in the low risk category, then there's absolutely no reason why you shouldn't be self-managing that. But I would say, make sure you know who to contact if you were to run into a problem. But I think that's great news that you're still in the low risk category after all these years of managing your condition. But to put your mind at ease, that means your circulation's intact, the nerves are intact, so you will know if something's going wrong with your feet because you'll be able to feel it. And if your circulation is intact, then if you do end up with a break in the skin or end up with a problem, then your chances of that healing without any problems are greatly increased if your circulation is intact.
That's great, thank you. Lynn says, I see diabetic foot cream for dry skin in the shops. Is it any good?
Well, I wouldn't say you had to go with something that specifically said diabetic foot cream. Like I would say, if you're in a supermarket, I wouldn't specifically go for something that was diabetic chocolates or diabetic jam. I would say any good moisturizer cream is absolutely fine. E45, something like that, or you might, or Diprobase or something like that, which you could probably get in prescription. But as I said during the presentation, if your skin is especially dry, I would use a urea-based cream, because that works very well on somebody who has diabetes and their skin. It's not so much the type of cream you use, I would say it's the frequency of using it. So if you do have dry skin, using something like an E45 cream or a Diprobase type cream on a daily basis is much better than using something that you might perceive to be very expensive and very good, which is possibly no better for you, and only using that once a week. So it's regularly using a good cream, but if your skin is very dry, make sure it's a urea-based cream, and that should be able to be on prescription for you.
Great, thank you very much. And Peter says, brilliant, a helpful reply. Many thanks, Duncan.
Okay, thank you.
Says, thank you for the presentation, as I've never heard anything formal about this at all before. So thank you very much. I personally would like to ask, in this COVID time, and in fact, Bex has asked this question too. Do you know roughly how long it will take foot screenings to start again due to COVID? I've not had my feet checked in over a year. I'm not worried, but I get mine done at the GP, who are refusing to check just now.
I wish I could answer that. And everywhere will be different. Obviously, things are being prioritized at the moment, and there may be you may be having there may be more consultations over the phone, but which which is so important at the moment, that we get involved in be involved in self-management and checking their own feet. I cannot say when all screening programs will resume, and this is not just diabetic foot screening. There are a lot of screening programs that have been put on hold. But as long as, I wouldn't be too worried about that at the moment, as long as you're following the guidance of checking your feet daily. And if you do notice a problem, knowing that you will be seen. You might not be seen for a screening appointment, but if you have an active foot problem, or if you're worried about something, you will be seen. And if you have a break in the skin and you are worried about that, or you have any areas of redness, anything like that, I would phone up, and I would, whether that's the podiatrist, whether that's the practice nurse or the GP, and explain, no, I have diabetes, I have this problem, I need to be seen. And I would be quite forceful on that, and make sure you are seen, because if you have any of these problems, it is paramount that you're seen straight away. So I wouldn't worry too much that you're not getting your screening at the moment. Hopefully, when we come out the other end of this pandemic, everything will resume. But check your feet daily, and if there is a problem, seek help, because the health service is open.
That is a very helpful and very reassuring answer. Thank you. And Beck says, thank you. I don't have any foot problems, but your answer is very helpful. So there are no more questions in the chat. We have a couple of minutes left if anybody else has any more questions. But otherwise, I will say thank you very much to Duncan for your illuminating talk. It was very enjoyable and very informative, and I'm very grateful that you came to FFL for this talk.
No,
So,
delighted, because I'm delighted to share this information, because as I said at the beginning, diabetes is a self-managing condition, and the more that you know, especially around your feet, and it's not about doing things in a complicated manner. It's about doing the simple things, but doing them regularly, and checking your feet and knowing what to do and what to look out for if you do see a problem. And when screening starts back up, knowing your risk and knowing what that means for you as a person with diabetes, and knowing what the healthcare professionals surrounding you should be offering you according to your risk.
well, that's great. Thank you very much. I think we'll leave it there.
Okay, thank you very much indeed, and I hope you enjoy the rest of the conference.
Thank you, Duncan.
Cheers.
Bye.
Bye.
Thank you. Thanks. Bye.